Hello, hello.
Hey,
how y'all doing?
good.
John, did you just go on vacation? I want to hear updates.
We were in Greece for 2 weeks.
Oh, Chris loves Greece. We're about to go on an entire,
We are
you just
changing the
opened a
topic
can of
of today's
worms.
live stream and talking about. I'm half Greek, John.
Oh, I didn't know that. Okay.
Yes, my mom's fully Greek.
Okay,
In
I was going to say not
Chicago-
the Trondsen side.
No, that's my dad. The Norwegian side. Kalamiris is the Greek side.
Oh yeah.
And as you know, in Chicago, it has one of the largest Greek populations, and that's where my mom and I are going after the conference.
Oh,
So
nice.
if we want to make this a whole Greek live stream, John, I want to hear pictures. What islands did you go to?
Let's do it. So we went to Crete, we went to Santorini, but we flew into Athens. It was a tour. So we spent the first week all learning about the Acropolis and the Olympia, and also I got to stand on the podium where the ancient Olympians would stand if they won and got an olive branch on their head and stuff. I learned a lot of cool stuff. I've always been into history, and it's just cool to learn all that's part of the cradle of civilization.
Yes.
Yeah, we have a running joke that we cannot make it through a live stream without Chris bringing up either Greek food or something Greece at some point. So that's why today I was like, oh, geez, I shouldn't have that.
Liz is like, John, you couldn't have gone anywhere else. Wait, what was your favorite food?
We're
John,
not talking about OCD.
What was your favorite food dish?
Yeah, well, the Greeks. I've always loved Greek salads, but the feta that they have is amazing. So that, and just souvlaki and gyros and stuff like that.
And thank you for saying it correctly.
Oh my God, there was someone on our tour that was like, I want to have a gyro.
No.
No. I can't.
I'll never forget. We were at a Greek restaurant and this guy didn't like the and he was yelling and he's like, I know my gyros. I am a gyro connoisseur. And I'm like, you cannot be a connoisseur if you don't speak it. Real quick.
Can't say it correctly.
Yeah, real quick story, John. When we had the BTTI down in San Diego, my family owns a Greek restaurant down there, and I took all the BTTI faculty. And I think my aunt had a little thing for Eric Storch, kept giving him free shots of ouzo, and kept taking shots with my aunt. So that's my fun little Greek story. But yes, I'm so excited you love my people.
No, the people are so wonderful. Everyone is so nice. It's a fantastic. I just learned a lot about. We've always wanted to go there, and so finally made it over there. And we should have a BTTI over there. I would love to be on the faculty.
Yes.
Yeah.
Yes.
I agree. Who do we put that up to?
Alec, who do we talk to?
Okay, talk to Alec and Eric. So this is awesome, and I am so excited. Well, first of all, I do really want to go to Greece on my bucket list. So with my kids, but I feel like it's like an older kid trip, because there's not as a lot of walking and doing. But anyway, today is going to be exciting. It might be a little controversial, and I always want to say that up front because for some reason it feels like when we present research and evidence, a lot of folks feel like we're presenting our personal opinion instead. And so I want to make sure that before we hop in today, we just really spend some time clarifying that today we're going to talk again, as we did 2 weeks ago. 2 weeks ago, you guys know we brought on Dr. Hudak to talk about the updated, Dr. Poskar.
Poskar.
Did we bring both? Okay. So Poskar and Hudak helped write it. So I'm always like that. But we brought on Dr. Poskar to talk about our treatment recommendations, the updated recommendations around medication for OCD that IOCDF has published and that everybody can have access to. And we told you guys we were going to follow that up with the behavioral treatment recommendations, which in our opinion are the most important because we know that you can't benefit from anxiety disorders, OCD disorders without doing behavioral interventions. So Dr. Abramowitz was the lead of the behavioral intervention kind of text inside with these new treatment recommendations that are updated on IOCDF's platform. We'll put the link to that in the comments box. And today we're going to dive into how do we get where we are? What has treatment looked like over time? And why does ERP remain the first line most recommended gold standard treatment for OCD? I want to share my own thoughts before Chris and John do, and then we'll hop in, of just sharing that I recognize how personal this can feel because many people who, do what they might think is ERP or CBT may not get the full benefit. And I can recognize that. We can talk about that. As you guys know, we've done a live stream before. It was actually with you, John, where I talked about how if somebody were looking at my personal outcomes, the first decade of my OCD treatment, they would have said, for all intents and purposes, oh, ERP doesn't work for Liz, when it was actually because I wasn't really doing ERP. I was one foot in, one foot out. There were a lot of reasons why ERP didn't work. It wasn't because ERP itself didn't work as an intervention. It was because of my application of ERP or my clinical applications and exposures that I was getting at that time. The second piece, which you guys know is my biggest thing right now, is comorbidities, right? ERP is not evidence-based for other disorders. It is evidence-based for OCD. And so a lot of times when we hear people talking about ERP not working and we're doing clinical work with them, because John, I know you do, and Chris and myself, but those of us that do intensive, or we see patients who have been in lots of different treatment programs, receive lots of different treatment, one of the biggest things I see is that what they're actually talking about isn't OCD. It's better explained sometimes as personality disorders, as trauma disorders, right? Other things that are going on, or there may also be OCD, both could be true as well. And we know that ERP is not going to work if it is not OCD. So I want us to just really, as we dive in today, I want you to really be thinking about, if ERP isn't working, why isn't it working? And understand that these treatment recommendations are going to come from science. They're backed by years of both literature and research, and they're not something that is a personal opinion of me, Chris, or John.
Well said.
Cool.
Yeah, no, I'm glad you put that caveat. We've always said, I don't currently sell anything that, or I'm not sponsored by ERP. If I say ERP, I don't get a quarter of my account. So for me,
that would be great though.
Well, I think it comes from a personal lens for me. I mean, as you all have either experienced or heard, I went through a lot of bad treatment till I found the right treatment. So what I love about these guidelines, we've talked to Sanj and Paskar as well, and we're super excited to have you on, John. It's just, so many of us out there have unfortunately gotten poor treatment, whether that's somebody that specializes on psychology today for 48 different disorders, and they've taken a class on ERP and are trying to do it. There's people out there that I hear are seeing a therapist once a week, yet they have a Y-box score of 36 with a lot of comorbidities. But I think for me, a lot of us are at our lowest point in our life when we go for our first treatment provider. And for me, it was think about a nice place in your head when you have bad thoughts. Or, I had one clinician tell my parents, I think he's going through this because he's gay. I was getting very poor treatment. I think it was a year and a half till we finally landed on good treatment. And there's horror stories longer. So that's why I'm just grateful to you guys, Dr. Abramowitz, because I know this was a labor of love, a long time. But just like you were saying, Liz, this is really to help the consumer really find evidence-based treatment out the gate so that they can get the best care that they can and they don't navigate poor treatment for years.
Thanks. Yeah, it's a labor of love to be involved in all this stuff. I feel really passionate about it.
Yeah, so I would say if you could start, Dr. Abramowitz, if I'm somebody with OCD and I'm suspecting I have a diagnosis, or maybe I have a diagnosis, and I come across these guidelines, how are they supposed to be used as a consumer? What should when I look at those guidelines? And then same question for newer clinicians who are making decisions about what trainings they're going to get in order to treat OCD. How can these guidelines navigate both somebody with OCD and their family, as well as a therapist that's practicing evidence-based treatment for OCD?
Yeah, that's a great question, Chris. So what the committee did, and the committee was myself and a few other folks. So Steve Paskar was part of that. We kind of worked together on both, but he obviously took most responsibility for the biological side and me for the psychological side. And what we did was we went to folks who have expertise in all the different types of treatments that we know sometimes get used for OCD, whether they have research support or, irrespective of how much research support they have. And we asked those folks to do a number of things, to write, a blurb for the website that would have a description of the treatment. So what can you expect if you do this therapy? And then a little bit about the research background. So what do we know about the effectiveness of this treatment? What can we expect? What can you expect if you're doing this based on the research that's been done? And we wanted folks to talk about the quality of the research. I could do a study where I treat 10 people with a therapy And that's research, but it's not good research, right? Right? We want studies, we want hundreds of studies with hundreds, if not thousands of people, with OCD in the studies, in all different parts of the world, with all different, types of providers, and they're diverse samples, and they need to be randomly, assigned. I don't know how much we need to talk about that, but there are different types of studies that are more qualified to speak to the efficacy of a treatment than others. So what we did, so everybody handed in their, it took a while, like over a year. Everybody finally handed in their documents, and we went through and we looked at the state of the research, because that's the best thing, that's the best evidence that we have about how a treatment works. I'm not saying it's perfect evidence, because it's not. The research is based on averages. It's not, treatments are not one size fits all. But based on the best estimates that we have from the most rigorous research, we group them into, like, what are the first line treatments? What are the second line treatments? What are adjunctive? In other words, do this along with the first line. And that was based on what the research, what the science tells us. So essentially, we made it easier for folks who have OCD and their families to be able to, instead of going on Google Scholar and inspecting all the research, we had some folks with expertise do this for you. So what I would suggest is reading through these different approaches and considering, what does each approach entail? So what would it look like to do these therapies, along with what's the evidence? What's the research? So the first line treatments, exposure and response prevention, medication, the combination of those, that's just where we have the most evidence, and the most evidence suggesting that these can work really well. So instead of you having to go and look up, which consumers should do, right, is really be knowledgeable, go to the research, right? Don't just go what some person on Reddit told you to do. You should, right? You should go and see for yourself. And I tell people when I meet with them in my office the same thing. Don't take my word for it. Like, go to the literature, go look this up. So, yeah, go ahead. Sorry, I'm
yeah, I think, no, this is great. And I think that, I do believe that sometimes individuals feel like, when we say this is first line, that like takes away their opportunity to become informed consumers. And I love what you're saying, which is actually it's the opposite, right? We're here to tell you, like I always tell patients, they're like, well, I'm skeptical of how that would work. And I'm like, good. It'd be weird if you weren't, right? Like if you weren't skeptical about a treatment you've never tried for a disorder you've been living with for a really long time, that would be kind of strange if you're just like, yeah, Liz, like do ERP with me. And go look it up, understand it, listen to other people who've experienced it, but also ask questions to your clinician.
Yeah.
I think a lot of times people ask Chris and I this all the time, where we've gotten this question on live streams where people will say things like, can we ask our clinician questions? Can we tell them if we feel like that exposure doesn't make sense, or like, I don't really know why they're having me do that? And we're like, oh my gosh, yes. Like I hate that we have to say that, because that should be a known, right? A clinician should be creating a space where if something you're doing doesn't make sense, or you feel like this doesn't really fit for me, or this, I'm wondering if this actually is OCD or not, because this is how it looks a little bit different, doesn't fit into a traditional OCD mold. Talk about that. Ask your clinician about that, right? And if they're not willing to have conversations about it and think about that's a red flag.
Yeah, it's exactly. I couldn't have said it better myself. Yeah, if you're working with someone who can't be open about that and willing to be asked questions and maybe even challenged and explain to you what they're doing, I don't think you want them as your clinician.
Yeah.
Yeah.
What, John, if you could help me understand, because I think this is something that I'm struggling a little bit within our field. So I have a sleep disorder, and what I love about the medical field is they're very clear on what the order should be. So you go, you get the sleep study, they start you off with a CPAP. If that doesn't work, there's different devices. Nobody cares, but so I won't go into it. But there's a very order. And in fact, like in order to move to the next thing, you have to have tried certain things. And your provider has had to say like, hey, this person gave the CPAP, this kind of try, let's move to that. What I'm noticing on the behavioral side, and I feel like the medical model when we're talking to Steve as well is pretty clear that way. Like there's certain restrictions if you want your insurance to cover. What I think I'm seeing on the behavioral model side that worries me is there's people, clinicians that are not using frontline treatment, or frontline treatment may be something they're trained in, but I'll see comments all the time like, oh, I'm using this modality because I really like this modality more. And like, I don't even really use ERP anymore. I'm only using this modality. And I think what frustrates me as a person with it is if I'm going to a provider after looking at these guidelines, my thought should be, hey, I should get ERP and medication potentially, try a higher level of care. If that doesn't work, there's these great adjunctives. And if that doesn't work, we have these great second line treatments. But that's not what some people are doing. That's not what some people are marketing. They're like, I use this modality. I like this modality more. I prefer this modality. Why in our field are we doing things like preferences and kind of that stuff versus really taking the science seriously and using that as our guide?
It's a great point, and that's, it's always been that way in psychology, in the psychological treatment of mental health. Part of it, I think there are a number of factors. I think one is, there's confidentiality in psychological treatment and psychotherapy. And I think that's just different than in other areas of medicine. Of course, there's confidentiality, but the level of that is different. So just the way that clinicians can, once that door is closed, clinicians can do what they want. And it's hard to get, with psychological treatments, it's hard to have that oversight.
Right.
Once you get past graduate school, where there's a lot of oversight and a lot of supervision, where we're watching videotapes of our therapists in training doing this, once you're out in the world, you can do what you want. And if your clients and patients are not complaining about you to the ethics board or something like that, you can get away with it. It's not like taking a pill or using a device where it's like one size fits all. In psychological treatments, they have to be done and tailored to the person, and that can look a lot different. So I think that's one factor, is that the level of oversight just isn't what it is, for better or for worse. I don't know if there's much we can do about that. I think the training, folks get different types of training. It has a lot to do with where you go to graduate school to get trained, or what type of degree that you get, or literally like, who is your advisor and what do they, what are they interested in? That's going to have a lot to do with how you get trained. And then I think also just their personal factors. So some therapists, they don't believe in the idea that let's take someone who has OCD and let's have them approach something that they're afraid of. Right, what we do in exposure therapy. I can't possibly do that to someone who's already struggling with anxiety, do something that's going to potentially make them more anxious. And there are just some people who can't see that there's long-term, good in doing that. Their idea is, a different approach. We need to, talk instead of get up off the couch and do stuff.
Can we talk about that for a second? Just because this is like one of my biggest other issues right now, is because I think it's important for people to know that clinicians can tout treating certain disorders and being trained or like doing ERP, CBT, yet actually have zero training in it and really have zero skill set appropriate to be able to treat OCD. And so I think that it's just an important thing to note, that we know the difference between when we can look at someone's, website or wherever, being like, oh yeah, they look like they have appropriate training, or no, they don't, I wouldn't go to them. But why is that the case in our field? Why is it so unregulated? That's so infuriating to me as somebody who's trying to close the gap between diagnosis to evidence-based treatment, when it's like, well, yeah, they can, not a million, but I don't know, maybe, but a ton of people might say to us, well, I've done OCD with a provider who specializes in OCD, and sorry, I've done ERP with a provider who specializes in OCD and ERP because they found that on Psychology Today, but there's actually no vetting around that. And maybe all the providers they've seen so far, I cannot tell you, as I'm sure y'all can't, the number of patients we've seen who think they've done OCD treatment and they have not.
Oh yeah. No, you're hitting on exactly the problem with that. Is there's not the kind of oversight. I think some of it has to do with just the type of treatment that we deliver. It's not like, here, let's get this pill from the pharmacy and it's the same thing for everybody, and and here's what you do. And there are pharmacists who are kind of checking our work and all of this kind of thing. In the mental health and the behavioral treatment, cognitive behavioral treatment, it's up to the clinician to do the therapy. And I can go to a weekend workshop on ERP and call myself an ERP therapist just as much as I could go to grad school for 7 years and then do a postdoc and call myself an ERP therapist. And unless, I pity the poor person with OCD who doesn't know the difference, unless you go and you check out that person's credentials. And it's so important to do that and ask the questions before you get working with someone.
Well, I think, I don't know if you feel this way, Liz, but I think one of the things as this role in hosting this live stream, this stuff I do with the IOCDF, one of my biggest important kind of internal things that I always make sure is that what we are putting out is absolutely the best thing for the client, and everything is evidence-based and everything is backed in the research that people, great minds like you, do. And I've been fortunate, just because I'm a nerd like that. Like when when the guidelines came out, I've been fortunate to have been trained in all of the all of the modalities that came out. Was able to do with Ellie Leibovitz, the space training, which I thought was very great. I did the inference-based CBT training with OCD Training School. I did the Reed Wilson had a program to learn metacognitive. So I love that there's all these great options, and I always find ways to use them with clients. With that said, what I'm starting to see people promote with these guidelines is it's kind of like a 31 flavors, right? Like, oh, we have all these options. Now you can pick and choose which one you want to use. Why should people still follow the guidelines in the order that they're going? And I know I'm kind of harping on this, but I think when you're talking about training, my training was in a master's of science. We had to do a thesis, we had to do research, and it was just so important to me to follow. At the time I went to grad school, there's a lot of stuff coming out for trauma, and it was like people were using EMDR for everything, right? And even one of my professors was a lead EMDR trainer in Orange County, was like, this has gone awry. Like, this is not what EMDR, it shouldn't be treating OCD and all these other things. So what I'll see sometimes is a client will have tried ERP maybe for like 8 sessions. It might have not gone as it should have because of family accommodations or comorbidities, but people are quick to jump to other modalities. Why should someone start with the frontline treatments first before they move on to other things? Yeah,
well, they simply put, they have the strongest evidence base, the strongest research base, the most studies that have used rigorous methods that have the best results. The second line treatments, that doesn't mean that they can't work. Right? I'm looking at it right now on my computer, right? ACT can be helpful, cognitive therapy, inference-based therapy, metacognitive therapy. They can all be helpful, and we're not saying don't use them. The evidence base is just not as strong, and maybe one day it will be, but at this point in time, 2025, the evidence base is just not as strong. There haven't been as many studies conducted with as many patients with the rigor that we have for exposure and serotonin medication. And then, third line treatments and some of these more emerging treatments, they're very, very experimental, maybe 1 or 2 studies, or maybe, very preliminary, studies that have come out. So that's, I think, go ahead.
Sorry. The one thing I'm, by the way, in charge of, John, I am trying to get it done quickly, but I want to do it right, is updating for the treatment recommendations. I'm going to write a section for IOCDF on levels of care and really talk to people, because I think that's important for us to talk about too, is I often see people saying, ERP didn't work for me, but when you look, like Chris said, at their YBOX or DOCS, their severity levels, and you see that like, yeah, the ability to maintain treatment in between all that time of a weekly session, it wasn't ERP, it was the frequency of ERP. It was the need for more intensive treatment. And so I think that's an important piece for us to really make sure we're bringing into the conversation is I cannot tell you how many people ask me to do a consultation or something with them, clinicians, and I do, no problem. But they're like, I've been stuck with this patient, here's why. And I'm like, well, you're going to stay stuck with this patient because they're not a fit for an outpatient level of care, maybe because of complex comorbidities, maybe because of other stuff going on, maybe because their OCD is just way too severe.
Yeah. I mean, and that's the thing, like, you know, I think I've said this before many times. If you've met one person with OCD, you've met one person with OCD, right? Everybody's different. And the therapies, of course, are, you know, they have to be tailored to each individual person. And there's so many different factors. How good is the therapist at tailoring it? How ready is the person to do the therapy? There's so many different factors that come into play. And I think what you're touching on, the importance of, yeah, should I do this once a week enough? Should I do this more? Should I do this less? Can I do this less? Those are all factors that are really important. And you know, and that's why something like, you know, AI therapy and all of those kinds of newfangled modalities, like there's a limit to how effective they're going to be. That's because right. This really does need to be tailored by a human being who gets OCD, who understands it, who can tailor it to a person with OCD. And they're idiosyncratic, meaning they're very specific obsessions and rituals and all that stuff.
Yeah, if anything, I'm finding my clients are using AI to compulse more educating, like a more concise
reassurance checking.
Yeah, reassurance checking. I'm like, please no. But right. I'm glad you brought up higher level of care, Liz, because that's the other thing is, you know, I think, you know, we all are trying to figure out better ways to help our clients. Nobody has a reason not to. We're open to what the research says, but I see a lot of people that are doing once a week telehealth sessions, but they're not even leaving their room. You know, they're using the bathroom in their room. They haven't eaten a real full meal in you know, each day. And there's these really, really difficult challenges. And going on a telehealth session once a week is just not going to do the same that somebody who would be in a higher level of care could do. If somebody's a new clinician, John, and they're reading these guidelines, what should their first steps be if they want to be a provider and treat the OCD community? What could these guidelines help tailor with their training?
Yeah, well, so hopefully the kinds of treatments that you're going to learn how to implement, right? So we need so many more clinicians who can treat OCD because there, you know, millions of people who have OCD, not enough clinicians. So if you're getting into the field, want to help folks with OCD, you want to learn those most effective treatments, those first line treatments, or really it's one, exposure and response prevention. Start there. That will get you a long way with working with folks with OCD. It's not a panacea. That's my main modality that I use in therapy. And I'll be the first to tell you, it's not a panacea. I don't help everyone. But it gets you a long, long way. And then start to branch out about some of these other, you know, treatments. I infuse a ton of ACT into ERP that I'm doing. Sometimes we use cognitive therapy because those adjunctive and second line treatments, they can be effective. We're not saying they're not effective. We just don't know enough to be able to say you should do that before exposure and response prevention. It's honestly... And
sometimes they're like effective in your toolkit for the patient sitting across from you, right? So like I had a patient this morning who we're doing clear OCD work. And then, you know, one of the things that got brought up is he was like, oh, you know, I do think part of why I'm struggling to give up these rituals is because they did serve some comfort for me when I was going through different traumatic experiences in my life as a kid, right? Because there was also some trauma. So it's like, oh, like, let's actually do a thought challenge worksheet on that. Let's talk about that cognitive distortion and like that belief that this actually kept you safe versus it, you know, why it feels like it did versus did it really? And can we start to break that apart or do a check the facts DBT worksheet? Like there's things where I would tell you, I'm still not doing that worksheet for OCD, but I'm doing it for this like distorted belief that you have that we do need to kind of unravel while we also do ERP treatment, right? And I think there's this conception that I actually had a patient once who said to me, you know, she was a friend, not a patient. So she was a friend seeing somebody, a provider I knew that I had referred her to. And she said, hey, can I ask you a question about my treatment? I said, sure. She goes, I feel like I just have a lot of stuff coming up in my marriage and in my life right now, but I know I'm only doing CBT, so I can't talk about it. And I was like, what? And she was like, well, I can't like talk about other stuff, right? Because we're only here to deal with my current anxiety. And I was like, no, you need to be talking about other stuff, because guess what? Just because we are ERP trained doesn't mean we shouldn't also have other tools and be able to meet our patients with what is showing up right now in your life.
Yeah.
And I think that as somebody who works in one of the highest levels of care for OCD and sees patients who have had years and years of failed treatment, our patients are showing up with complex comorbidities, right? It is very rare that we are treating a patient in res with only a diagnosis of OCD, right? There's often a comorbid personality disorder, comorbid maybe eating disorder, certainly almost always depression and a comorbid other anxiety disorder, but lots of comorbidities that for us, like, we would not be able to have the outcomes we have at our level of care if every provider here only did ERP. At the same time, we also 100% would not have the outcomes we have if every provider here didn't specialize in ERP, right? So both are true. And I think that's really important to talk about and acknowledge, and just, think about when we might use other interventions and why it's useful. Because guess what? Like Dr. Abramowitz said, no one shows up having OCD the same as any other patient that shows up having OCD. And so they've got other stuff going on.
Yeah, if you could talk to that, Dr. Abramowitz, that was kind of be my next question. Like when we were talking to kind of what Liz was just saying, when we were talking to Dr. Poskar, it's like you start with these medications. If those don't work, you add on the adjunctive. If those don't work, you go to second line, then you might try TMS. I know it's a little bit different for us, but when you're working with a patient, let's say you have a strong foundation in ERP and you're starting there, how do you know to maybe either move up to a higher level of care, or maybe add an adjunctive, or eventually get to a point that you start to introduce a second line treatment? How can a clinician kind of make that decision when working with a client?
Yeah, when you're well trained in how to do ERP, you also understand its limits. And you also understand that doing ERP is not just about, let's make a list of things the person's afraid of and bam, 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 let's just do that, right? Face them. There is a whole, you got to educate the person about OCD, about how ERP works. You have to do a lot of foundational work before you're ever ready to start that first exposure. And understanding, as the clinician, understanding how OCD works, understanding the comorbidities and how they work, and will I be able to implement exposure? Will this person be able to do the exposures and benefit in the way that they need to and glean what they need to from those exercises, given the comorbidities? So just as an example, if the person has, social anxiety or a snake phobia or something like that, yes, your kind of understanding of how OCD works and how anxiety disorders work and phobias would say, absolutely, you can still do ERP. You might even incorporate some exposures for those other things in with, ERP for OCD. But if the person has a comorbid substance use disorder, right, or they have a psychotic disorder or bipolar, something where their cognitive abilities are going to be strained, maybe because they're using substances and they're not able to, substances have a psychoactive effect, right? If they're abusing alcohol or drugs or things like that, or if they have psychosis, right? And they're having hallucinations and delusions, right? Or if they have, what were the other ones I mentioned? Things that get in the way of cognition, that are going to get in the way of learning. ERP is a learning therapy. Then, right? Then or someone who is in a manic phase, who's not able to really sit down and do the stuff because they're kind of, manic and doing all different things. That's when you're going to say, hey, this ERP might not be the best thing. Let's start with something else, or let me refer you to someone else for something else. And then once that's under control, we'll work on the OCD. That is, so, you don't want ERP to be a hammer and everything's a nail. And just as important as how to implement the therapy is also understanding its limits.
Yeah.
Well, I don't know if you remember, sorry to interrupt, Chris, but we were doing, I think this was like probably like 10 years ago, John, on like a Peace of Mind or some webinar that we were doing. We were talking about substance use and OCD treatment. And I think you said something along the lines of like, because a lot of in the field, there was a lot of like, well, we should be, it's not fair that people have to be sober before they do OCD treatment because their OCD might be why they're using. And I think you said this, so correct me if I'm wrong, but you said something and it stuck with me of like, if you're not sober, the mechanisms of ERP would never work.
Right.
So like we get it. And of course that makes sense. But like at the same time, ERP doesn't work if someone's not sober. Right. It was such like it was so important for me. I was very young at this time to hear this, to be like, well, yeah, of course. And to apply that to so many other things, that if you are not in a place where learning can happen, right? I love one thing I really learned from Brene Brown is you can't learn if you're experiencing shame. So you think about when you're teaching your kid a math problem, right? If you start with, I can't believe you don't know how to do this. Right. Do you think they're going to hear the next thing you try to teach them? No, because like they're feeling shame. They're feeling like they're not going to be in a space to learn, to absorb, to understand. And yesterday I was doing a checkout. I do a checkout with all of our patients here when they're discharging. And it's my favorite thing to do, to hear about what worked and what didn't. And, one of the things she said to me is, she said, Liz, sometimes I realized that you or someone will say something and it clicks. And I'm like, and I sit back and say to myself, I know I've heard that 10 times since I've been here. That is not new knowledge, but I was finally in a place to really learn it. And it's just this constant reminder that if you could just hear about ERP and it work overnight, you wouldn't have OCD, right? You're just regulated, you're anxious, like your insight is low. We have to build a lot of that. And a lot of other things have to be working correctly, and you have to be in the right place to be able to do treatment.
Yeah. Well, going back to what you're saying too about the limitations, I mean, I think, I don't see the same type of patients that Liz sees at a residential level. I do a one-on-one IOP. So we see people typically that have done an IOP, maybe in more of like a group setting, but want that one-on-one care before they end up going to either a PHP or residential if they need it. And the way that I look at the guidelines and the way that I do treatment is like the ERP is the foundation, right? Like that's the fundamental foundation that I start every client with. And then it's like, as I'm working with a client, that's what I love. People are saying, well, I love that we have options. I agree with that statement. But I think the way that I read the guidelines is, okay, I'm working with ERP and I'm noticing a client is just not connected with the treatment because there's no value. They're not bought in. They don't have a why. And that's where ACT comes in beautifully. Or Allegra Caston's a good friend of mine. We always say, like, sometimes there's just not enough CBT, the cognitive part in ERP. Some people can't just touch a doorknob and then use their phone, right? They feel like a monkey, like touch that, do that, right? So you're really slowing that down. And with cognitive therapy, helping somebody look at those distortions, or if inference-based is helpful there for inferential confusion, or maybe there's a really big family component and enmeshment, and space would be great for the parents or family accommodation. So that's how I kind of see the options, is like you're going in with ERP medication if they need it. And as a trained clinician, and you're starting to notice what the client needs, or obviously with Liz, who works with a lot different comorbidities than I probably see at my level, you're figuring, does this person need work with sobriety or with, eating disorder? I think, though, how can people see the guidelines as that and not like you pick which therapy on there and that's what you use? Because that's what I'm getting nervous about, because people were rejoicing the guidelines, which I'm glad, but they're like, see this treatment that I only use and I don't use the other ones, even though it's second line or it's an adjunctive. Like, I knew it. See, it's validated on these guidelines. And it's like, no, I don't really see it that way.
And that, to be honest, I wasn't all in when IOCDF was like, let's do guidelines. Because for exactly what you're talking about, Chris, people can be too rigid about them. And their guidelines, they are not like demands or commandments or things like that. That's why they're called guidelines. Yeah. Everyone's going to be a little bit different. Part of, being a trained clinician means being able to figure out who's going to need what. And sometimes there's trial and error that you need to do. I like you guys are saying, I've worked with plenty of folks that, we start down the road of ERP and it becomes clear either, we got to step back here and do some ACT to kind of get them better ready to do ERP. I'm not going to try that first exposure and have them, not have it not work out. I'd rather, continue.
I love that.
Yeah, and I've had folks that I've referred for inference based. We were just not getting anywhere with exposure. They couldn't do it, and weren't getting the idea of like I got to be able to accept these thoughts. And this is someone a couple of years ago I referred to a colleague who does inference based CBT, ICBT. I never heard back from the person, so I'm assuming that that's a good. That worked out, but you got to know the limits. Any treatment that you do, not just ERP, all treatments have limits, and you got to know, what those are.
So I want to just say too, like to hop in for a second, I think it's really important for us to recognize that when we talk about each patient being different, it is also like one of the things I talk about in supervision all the time with our trainees is quit putting patients in boxes. Right. My trainees will get so into like, so is it this or that? Do I do this? And I'm like, I don't know. Like, you're going to have to talk to the patient about it and figure it out, because guess what? Do you know how many patients I've seen that I've treated their OCD and they're doing great? And all of a sudden, 3 months in, I'm like, whoa, I didn't know this was also going on, and that this is something needs to be addressed. And this is what the evidence-based treatment for that would be, because maybe OCD was loud and that was quiet. Maybe something else is loud and OCD is quiet, right? It's treatment, as Dr. Abramowitz and Chris are talking about. It is not something that I can say, here's my rule book, like, okay, I'm doing this. Everybody is different. Everybody is nuanced. We all have, think about the saying, right? We all know this, where you can grow up in the same household and you and your siblings can turn out vastly different, right? Yeah, because you're human beings with different makeups, I can have a conversation that Chris is a part of and someone else is a part of, and we all can remember it differently, because that's how the world works. It'd be boring if it didn't work that way. And it also means that treatment involves working and sitting across from the table with someone who has different experiences, different understanding of the world, and different, frankly, diagnoses.
Well, and that's, one of the great things about the cognitive behavioral approach is that we're focused less on the diagnosis. So, someone gets diagnosed with OCD, they have OCD. That tells us something, but that doesn't tell us enough.
Yeah.
Right? As a cognitive behavior therapist, and again, this is a good way if you're out there and you're looking for a good cognitive behavior therapist. A cognitive behavior therapist is going to want to know more than just that you have OCD. They're going to want to know about your cognition, so your thinking patterns, your obsessional thoughts, your catastrophic beliefs, and your behavior. So what do you do? How do you try to control those obsessions? How do you try to control the anxiety, the rituals? And a treatment plan in cognitive behavior therapy, and that's CBT is broad. Most of the stuff in the guidelines, ACT, ERP, ICBT, those are all cognitive behavioral treatments. They go beyond just knowing the diagnosis. But all those treatments are based on more than just, oh, you have OCD, here's what we do. It's based on, oh, you have OCD. That guides what I want to assess and learn about the person. But then it's that more kind of real specific information. That's what I'm going to use to implement a treatment plan, whether it's ERP or ACT or cognitive therapy or what have you.
So I want to dive into that for a second, and because this is so important. So earlier you brought up the analogy of just, ERP is much more than just touching the doorknob or doing these behaviors, right? And this comes into many talks Chris and I have done on core fears and underlying beliefs and what is happening, right? And it is so important for us to acknowledge that ERP should never be only this fear extinction model of, okay, let's list all of your triggers and let's just get rid of those triggers, right? I think Chris is what you're kind of talking about, that you and Allegra have talked about, right? Is that just doing that? Yes, we all know it kind of works, right? If you touch something you're triggered by enough, you'll no longer be triggered by it. But this is the problem that people with OCD think when they think about ERP. This is what they're talking about hating. Is it feels exhausting, it feels never ending, and it feels like a game of whack-a-mole. And the answer to that is if that's how you're doing ERP, or your provider who's doing ERP is doing it like that, you're right. That would be exhausting if your whole life, every time you're triggered and you're surrounded by triggers, you have to just do this fear extinction model. If every time you address one thing, something else pops up and you think that is your life and how it has to always be, of course you're saying, I don't want to do that. Don't sign me up for that. Find me something else. the reality though is that is like the first step of ERP. That is not all of ERP. And I think a lot of individuals, candidly, a lot of clinicians who are not really trained on ERP, when they read one manual or they read one website or watch a couple videos, that's how they understand it, right? They understand it at this surface level of like, okay, you're triggered, we expose you, we do behaviors, that's it. When all of us know that that is not where ERP ends. ERP should be about, yes, you're still doing exposures, you're still touching the doorknob, you're still doing response prevention of not washing your hands if that was your ritual. And you are leaning into and allowing space for the core fears that show up, the reason why that doorknob is triggered to begin with. And that is what actually matters much more than if you touch that doorknob.
Yeah. Yeah. You are doing exposure, not just to, anxiety will come up and then it's going to go down and you're going to habituate and everything's going to be wonderful. That's not, like you're saying, that's not how it goes. Exposure is, a treatment that extinguishes fear because it helps people learn new information. And in particular, it helps them to learn that stuff that they thought was very dangerous is not as dangerous as they thought, right? And the stuff could be situations like a doorknob. It could be thoughts like, what if I harm someone? It could be body sensations like I get a sensation down there when I have a thought about my baby, right? Some sort of sexual, And the idea of exposure is you have predictions about like, I can't manage the uncertainty or something catastrophic is going to happen, or I'll be anxious forever, or these thoughts will be in my head and I won't be able to go to work or, whatever. And the idea of exposure is to basically disprove that, to basically help the person to modify those beliefs, those predictions. And so we're doing it for a purpose, not just to make you as anxious as possible.
Right. It's not, although it is still a good tool, right, for us to learn that like we can be anxious and that's okay.
But anxiety doesn't last forever. That is part of it. Exactly. 100%. That is absolutely part of it. That's right. But that is just one part of it. And what I see a lot is that folks overlook that. Clinicians, overlook that.
Oh yeah.
Yeah, often, and it's often the clinicians who aren't as trained and haven't had as much background in like specialty care and these, and so I always give the quick example that John, a lot of the other res programs, they still do this, which you're going to be like, why, right? But at check-in and check-out, so at most res programs, you're doing 8 hours of like active treatment per day, and you're doing 2 active ERP blocks. And at most programs, at the beginning of an ERP block, they're saying like, what are you going to work on? Do you need support? What are your suds? And at the end of each ERP block, it's what did you work on? Did you engage in response prevention? And what are your suds?
Right.
And John, it drives me crazy.
Yeah, no, that's not enough.
Guess what? We don't care about, and we don't care what your suds were. So we don't even ask it, because if we're telling you anxiety is not dangerous, we can change your relationship with it. Why are we focused on it? So our program, it's similar questions, right? But at the end, it's, we don't ask your suds at the beginning, or at the end, it's what did you learn?
Right. Yes.
Like, what did you learn? Like, okay, I learned that I did a ritual and I got more stuck for an hour and that was a terrible decision. Okay, that's awesome learning, right? Like, that's not bad. We're not going to be upset about that. And there's a researcher who came to me once recently and she was like, well, can you add suds back in so that it can match up with when we do research on cross-sectional sites? And I was like, no, because, and it's not because I don't, obviously I want research to happen, but it's like, I never want to emphasize that anxiety matters, that anxiety is our, success measure of success.
Right. Yeah. There is a liability of focusing on suds. And that is that the person, the person with OCD is like, I'm only good to go if my suds comes down. And that's not true. There's a lot of learning that can take place. If your anxiety is high and you're still able to manage and get through it, you learn, I can manage anxiety. Anxiety is safe no matter how intense it is. Yeah. It's hard for a lot of folks to wrap their heads around because we think of therapy as, soothing and let's bring the anxiety.
Make me feel good.
Yeah. Right. Yeah.
Well, you were talking about it on a podcast recently, John, like the point, or Dr. Abramowitz, like the point of
John is fine. My name is John. It says John on there.
the point is not to like watch your anxiety go down. It's really to show yourself like, hey, I can experience anxiety and move forward in that day and get things done, and not stop what I'm doing and wait for the anxiety to hit a certain number before functioning, like learning. I was having a conversation, I won't say her name because I didn't tell her I was going to talk about this publicly, but somebody that works for McLean at Harvard, and we were talking, and it's like, you had kind of mentioned it earlier, John. She was saying, I think the reason some clinicians are moving away from ERP is, as a clinician, they don't like to see their clients in any distress. But she's like, what are we teaching? Like when people are like posting like, you know, you can do OCD treatment without exposures, without experiencing anxiety, without tolerating it. It's like, why are we championing that? We are teaching our clients that in life, you're going to go to an airport and someone's going to cough on you. You're going to drive and there's going to be construction next to you, and you can't stop the car and say, I'm not ready to tolerate anxiety, stop the construction. We're teaching people that anxiety is one of the many organic feelings that we're going to experience for temporary slots throughout the day. And, you know, one thing I didn't see as much on the guidelines, but I was really heavily trained in mindfulness and mindfulness-based CBT. And I tell clients all the time, it's like, I love that you're anxious right now. Let's prove to your brain that we can still go to Starbucks and order something, or you could still work on your thesis or your homework assignment and experience the anxiety. It doesn't have to be a mutual, like one or the other. And so I hope clinicians that are seeing this, that are thinking about going into our field, don't buy into this idea that having your client experience anxiety in a session is a bad thing. We are teaching our client that they are powerful beyond measure. They have strengths and they can trust themselves to be able to land on their feet, handle it, and still thrive despite some uncomfy feelings.
Yeah. Yeah. And you know what? If the anxiety goes down, wonderful. That's great. And you've learned that anxiety doesn't last forever. And the next time you can anticipate that you can do this. But it doesn't have to, like we're all saying, it doesn't have to in order for treatment to be successful. And so we don't want that to be the focus of treatment, is what's the suds, what's the anxiety level.
What did at the same time, what I
always tell clients, like you said, Liz, like, what did you learn? And how can that learning be universal? Like today we went to Starbucks and you're able to, you know, order, you know, with certain numbers you don't like. But you don't have to go to every store in the world and order with numbers you don't like. You've proven you could do it in this setting, that learning can be universal. And then how does it come back to that core fear? How have we weakened that core fear today? So I think incorporating all that stuff can be really helpful as well.
And I just want to throw in there two things that I think are really important. Anxiety will eventually go down if we quit focusing on it.
Yeah.
And I think that's super important, is that I think sometimes people hear us saying some of this and they take the takeaway is, oh, so I need to accept anxiety forever. I need to accept always feeling at this level of distress. And they're like, well, that sounds terrible. Like, that's what ERP is. Like, why, you know, no, that is not what ERP is. Now, during the process of ERP, yes, you need to be willing to tolerate anxiety. You need to be willing to feel distress. But if you actually quit focusing on anxiety, and we no longer are telling our brain, anxiety is dangerous, I can't tolerate this thought, and we're doing that universally, our anxiety will reduce.
Yeah.
So I think that's so important to know, and y'all hear me talking a ton about freedom over functioning, is that you can use ERP to function. And I did that for decades of my life, where every day I struggled, every day I had triggers, and I would just use ERP as a way to make it through, right? It was that kind of fear extinction model of ERP for all my symptoms, and it was awful and it was exhausting.
It becomes like a ritual.
Totally. It was a ritual and it was horrible. It was almost worse than just like not doing ERP. So it was just daunting. And it was like, oh, and the reason it was super daunting is because I believed that that's what treatment was. And I believed that was the best I would ever get, that, oh, if I can learn to function while having really bad OCD, that's great for me. Like, that is my best case scenario. And that is such the wrong message, you know, and we have really evolved in that. You know, John, when I was first treated 20 years ago at Menninger in Topeka, that actually was the message. We told people OCD is a chronic disorder. You're going to live with it forever. And with treatment, you can learn to like be functional, but you'll always have OCD. And I am working really hard for us to extinguish that language, because that language sends the message that we think using ERP to function is how it's supposed to work, because we're going to have this forever and we're going to always have the disabling disorder. Where the reality is I 0% chance would meet OCD criteria today, because I've used treatment, you know, decades ago. It shifted for me where I was like, wait a second, I'm doing this wrong. right? I am using it still to feel better versus using it to learn to change my entire relationship with it. And so think about that as a patient. And I do think sometimes the first, like learning to use ERP to function is often what happens first, right? That's kind of like, let's get you more functional. And then there comes this point where we're like, this isn't good enough. This isn't, I don't want to do this forever. And we actually have the power and the choice to do that. And you can live a life where you are not riddled with anxiety and OCD really at all. Now, that doesn't mean I'm never triggered. I'm a mom of 4 kids. Like, it doesn't mean stuff doesn't happen, right? And I can get activated in different ways, but it doesn't control my life in any way. And that's what treatment's about.
That's what treatment's about.
Yeah. We didn't talk about it as much, and I know we're coming up at time, but I think also client readiness is so important too. Mm-hmm. I've had clients come to me and I'm like, hey, tell me about the work you did with their last therapist. And they don't even remember the therapist's name. And I'm like, okay, you haven't even built that kind of relationship then. So I know we didn't really talk about it today, but I think that's something else also to think about is readiness. One thing, you know, I you guys both know, but I run a support group for family and loved ones. And it's really interesting to hear from a lot of parents around the globe that tell us why their loved one isn't getting getting treatment. I want to say one good thing I've seen kind of shift in the field over the years is we don't get many people anymore that say, oh, my son or daughter is afraid that they're going to have to do horrendous things like lick a toilet seat or, you know, swing a knife over someone's head. So I'm glad, because Liz and I have tried to do a lot of work on educating the public on that. But basically the first thing is like, you know, just no relationship with a clinician. It was like jumping into stuff. And I think that readiness and that building a relationship. But for a lot of people, it's just they're at a point where they've kind of given up and you know, getting the family involved in stuff. But I think that these guidelines will really help people feel rejuvenated, in my opinion, because it feels like we finally have a place that people can go to and say, hey, there is a guide and there's research that shows this work. And I just hope that people that maybe who have previously been a little turned off by treatment are more open and willing, because as Liz and I can be a testament to, treatment works. We're thriving. You can have 4 kids under 4 because you did the work in treatment. You couldn't do that.
I don't know that I recommend that, but you can do it.
All your kids are under 4? Oh my God, I didn't realize that, Liz. Wow.
I know. The twins are, you know, they doubled my size quickly.
Oh, okay, yeah, that'll do it.
Kind of banking up that gets you to the finish line way quicker. So
wow.
Yeah. But it is, you guys, it's just ERP can change your life. And I want to encourage you to use these guidelines to understand that ERP remains the most effective intervention, not because it's what we use and because we personally think it's what's right. It's because it's what data and research and decades of patient experiences and research tells us. In addition, I want you to really think about, have I gotten correct ERP? Have I used it correctly? Have I been in the right levels of care? If ERP isn't working, don't just jump ship, right? Spend some time thinking about why it might not be working, because it is the most effective intervention. And majority of the time, it is what's going to move the needle for your OCD.
Yeah.
My final thought, and then I'd love to hear from you, John. My quick final thought is, you know, I always tell people, because a lot of people will reach out to me that want to go into this field, and I'll always say, please don't become a insert modality here clinician. You shouldn't be a metacognitive therapist, an ICBT therapist, and a space therapist, right? You should be an OCD therapist that really follows the evidence and the scientific backed guidelines. Not just these, obviously, these are great and helpful, but there's a lot of research out there. So I tell clients all the time when they're like, what kind of OCD therapist are you? I'm like, I'm one that's going to work with every tool I have, all the training that I have, and I'm going to make sure that I'm doing with you what I know that the science does. So I hope we can move away as a field of people kind of, you know, becoming a treatment modality therapist. I think that's something that I hope these guidelines, at least to newer clinicians, help people see. Well, what's your final thought, John?
I would just say to that end, like, we want folks who are like research-based, evidence-based clinicians who know how to consume the research, stay up to date on that, and are only going to use the techniques that have been demonstrated in rigorous research to be effective.
Love that. Well, If you are here for the first time, I saw some people, real quick, somebody asked if a BTTI should still be the first stop for training. I think the BTTI through the IOCDF is absolutely amazing. Please go to that. Somebody called me amazing in the chat, so I just want to say you have good taste. And then Liz, when you were saying people can grow up in the same household and be so different, yes, I'm amazing and my two sisters are not. So I wanted to agree with you.
Last thing I want to say too about training, I think BTTI is absolutely number one of where I would go. Also consider finding a supervisor or some sort of specific clinical OCD program that you can also get that hands-on experience, right? BTTI will lay an amazing framework. It's an amazing groundwork. And what we know is that when you apply it is when you learn the most. So think about working or doing some sort of training at a specialty program, or at least with a supervisor who really specializes in OCD treatment.
And constant consultation in the beginning too.
Yes.
I just want to say quickly, if you're new to the live stream, I know some people ask questions we didn't get to. Typically, we spend the second half answering all your questions, but we really wanted to hone in on this. We rarely have Dr. Abramowitz on our live, so we wanted to take advantage of it, and especially now that we're rolling out the guidelines right before the conference. We will not be here next Wednesday because we will all three be at the conference. So if you're going in person to Chicago, please come up and say hi to us. We always love meeting you all. If you can't make it in person, don't forget at iocdf.org/OCDCon, you could still register to see the hybrid option, and you can watch a lot of these talks from the comfort of your own home. So we won't have a live stream next week. We will be back the following Wednesday. I hate that I can't memorize dates very well, but it's going to be that following
July 16th.
Yes, Wednesday, July 16th, we will be back, and we'll make sure to prioritize your questions because I know we didn't get to them today, but I always copy and paste them in a doc and we'll get to them, and we thank you for being here. But from Liz and I, John, thank you so much for coming by, and we will see you in person. We will get Greek food in Chicago.
Happy to be back anytime, guys.
We'd love that.
All right.
All right, take care, everyone. See you at the con. Next week, Chicago. Yes, I'm going to take you to Greek food if you want Greek.